So, today we'll discuss shock. It is a very common condition in ICU. In fact, it is the first topic, okay, for newcomers. So, what is shock? Shock is nothing but a mean arterial pressure of less than 60 millimeters of mercury, systolic blood pressure less than 90 millimeters of mercury. Clinically is present at altered mentation, or if we do ABG of a patient, so we'll have lactate more than 4. So what is basic problem is shock? A basic problem is shock is that there is hampered tissue perfusion and oxygenation. So our goal is to maintain tissue perfusion and oxygenation. Okay. So mostly cardiac index is less than 2.2 liter per minute per meter square in these shocks. So there are basically 4 types of shock: cardiogenic shock, hypovolemic shock, and obstetric shock. But we will discuss cardiogenic shock, hypovolemic shock, and septic shock here. So how this cardiogenic shock, hypovolemic shock, and septic shock are clinically differentiated? If we describe it, a pulse pressure usually it is less in cardiogenic shock, hypovolemic shock, and it can be more in septic shock. Diastolic pressure is less in cardiogenic shock, hypovolemic shock. It is very much less in septic shock. Extremities are cool in cardiogenic shock, hypovolemic shock, and extremities are warm in septic shock because there is vasodilatation. Nail bed blood return, it is very much slow in cardiogenic shock and hypovolemic shock. It is rapid in case of septic shock. In JVP, it is raised in cardiogenic shock because there is pump failure. It is very much decreased in hypovolemic shock because there is hypovolemia, there is less blood volume, and in septic shock it is also decreased. It is decreased. Respiratory crepes are there in cardiogenic shock or cardiac failure. S3 gallop is there in cardiac failure. In other two shocks, it is not found. If you do chest X-ray of a patient, cardiogenic shock, there will be a pulmonary edema. In hypovolemic shock, there is decrease in cardiac size. But in septic shock, chest X-ray usually normal. If we see site of infection, it won't be infection in cardiogenic shock and hypovolemic shock. But in case of septic shock, there is focus of infection. It could be a pulmonary focus, it could be urinary tract, it could be any brain or anything in a peritoneal, etc. So if we do 2D echo in cardiogenic shock, there will be decrease in ejection fraction, there will be decreased contractility. In hypovolemic shock, ventricles are collapsed, kissing ventricles are there. In septic shock, there is hypodynamic circulation. So there are other miscellaneous causes of shock which are described. So how will you assess cardiac output by different methods? There are different methods for assessment of cardiac output. Thermodilation technique, then waveform assessment, intrathoracic and esophageal Doppler is there. So basically these are classified. These miscellaneous causes of shock are classified: high cardiac output and low or normal cardiac output. We know since the preparation days. So high cardiac output causes are Paget's disease, then thyroid storm, AV fistula. In low cardiac output or normal cardiac output, different causes include anaphylaxis, spinal shock, adrenal insufficiency. Actually, this anaphylaxis, spinal shock, adrenal insufficiency, these are fluid unresponsive. And other causes, miscellaneous causes like pulmonary edema, cardiac tamponade, right ventricular infarction, these are fluid responsive causes. Pulmonary edema, cardiac tamponade, right ventricular infarction, these are fluid responsive. In fact, we give fluid in these conditions. Okay, thank you.